Canagliflozin and renal outcomes in type 2 diabetes and nephropathy. Definitions. Canagliflozin belongs to a group of new oral antidiabetics that exert their action by inhibiting the sodium glucose co-transporter type 2 of the renal proximal tubule. Reducing the concentration of blood glucose, it is indicated in adults with type 2 diabetes mellitus, alone or in combinations with other hypoglycemic agent 1.
In cardiovascular and renal events in type 2 diabetes. Canagliflozin is a sodium glucose co-transporter 2 inhibitor that reduces glycemia as well as blood pressure, body weight, and albuminuria in people with diabetes. We report the effects of treatment with canagliflozin on cardiovascular, renal, and safety outcomes. The CANVAS program integrated data from 2 trials involving a total of 10,142 participants with type 2 diabetes and high cardiovascular risk. Participants in each trial were randomly assigned to receive canagliflozin or placebo and were followed for a mean of 188.2 weeks. The primary outcome was a composite of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. The mean age of the participants was 63.3 years, 35.8% were women. The mean duration of diabetes was 13.5 years, and 65.6% had a history of cardiovascular disease. The rate of the primary outcome was lower with canagliflozin than with placebo, occurring in 26.9 versus 31.5 participants.
Application and nursing. Inform the user about hypertension risk factors, cause, treatment, complications. Have insights of communication with him, user, and family. If necessary, perform interconsultation with other team members. Investigate reasons for no complications with treatment and provide solutions.
Trial that compared liraglutide, a glucagon-like peptide 1 analog, with placebo in patients with type 2 diabetes and high cardiovascular risk who were receiving usual care. We found that liraglutide resulted in lower risks of the primary endpoint, non-fatal myocardial infarction, non-fatal stroke, or death from cardiovascular causes, and death. However, the long-term effects of liraglutide on renal outcomes in patients with type 2 diabetes are unknown. We report the pre-specified secondary renal outcomes of that randomized, controlled trial in which patients were assigned to receive liraglutide or placebo. The secondary renal outcome was a composite of new-onset persistent macroalbuminuria, persistent doubling of the serum creatinine level, end-stage renal disease, or death due to renal disease. The risk of renal outcomes was determined with the use of time-to-event analyses with an intention-to-treat approach. Changes in the estimated glomerular filtration rate and albuminuria were also analyzed. A total of 9,340 patients underwent randomization, and the median follow-up of the patients was 3.84 years. The renal outcome occurred in fewer participants in the liraglutide group than in the placebo group, 268 of 4,668 patients versus 337 of 4,672. Hazard ratio, 0.78, 95% confidence interval CI, 0.67 to 0.92. P equals 0.003. This result was driven primarily by the new onset of persistent macroalbuminuria, which occurred in fewer participants in the liraglutide group than in the placebo group, 161 versus 215 patients. Hazard ratio, 0.74, 95% CI, 0.60 to 0.91. P equals 0.004. The rates of renal adverse events were similar in the liraglutide group and the placebo group. 15.1 events and 16.5 events per 1,000 patient years, including the rate of acute kidney injury, 7.1 and 6.2 events per 1,000 patient years, respectively. This pre-specified secondary analysis shows that, when added to usual care, liraglutide resulted in lower rates of the development and progression of diabetic kidney disease than placebo. Funded by Novo Nordisk and the National Institutes of Health, leaderclinicaltrials.gov.
Pros and cons. An early diagnosis should be made first by urine test or microalbuminuria if it is diabetic, and then we must quantify the proteinuria by means of the 24-hour proteinuria measurement or the proteinuria index, creatinuria or microalbuminuria, creatinuria. The diagnosis for proteinuria is determined in a sample of the first morning urine. In case if positive, it must be confirmed in 2 or more times that they must be carried out at intervals of 1 week to 2 months and in each one. Also urine creatinuria to calculate the albuminuria ratio. Creatinuria tests allow us to quantify proteinuria of microalbuminuria. Usually applied in Ecuador. In the province of Los Ríos, he says the incidence higher, but still does not reveal features, because the study does not end. Esmeraldas will be next province in which Argentina, with its work team, will focus its research. Also, the Prometheus of the Cenesic mentions that in Guayas there is a prevalence of type 2 diabetes. This has to do with the fact that the body cannot use insulin. So by not doing so, sugar or glucose increase in the blood. And when this happens for a long time, plus other factors, they affect organs, especially the kidneys. Conclusion. Depending on the undiagnosed cause, it is possible to treat some type of kidney disease. However, many times, chronic kidney disease has no cure. In general, treatment consists of measures to control the signs and symptoms, reduce complications, and delay disease progression. If your kidneys manifest serious damage, you may need treatment for kidney disease ends.